you, Marina. Really appreciate it. Thank you so much. Good afternoon, good morning, everyone. Thank you for joining us for today's webinar and the discussion we'll have with some of the amazing leaders in the healthcare space. As Marina mentioned, our focus today is on how FQHCs are bridging clinical and social care gaps at scale. As some of the folks in the audience might be working actually in the FQHCs or federally qualified health centers of space. Some of you might be in the health plans, health systems, or community-based organization space. Most of you know that FQHCs sit at the center of clinical and social care divide every day. These community health centers are often one of the first stops patients that are navigating housing and food insecurity, behavioral health needs, chronic conditions, or other types of kind of social drivers of health are stopping at and asking for help and getting the help they need. The FQHCs are at the center of what's called this whole person health model nationally. And I don't think the challenge is that we don't know what whole person health is. How do we address the kind of the social care elements of health and the drivers that impact the healthcare outcomes? The core challenge is how do you execute and operationalize this at certain level of scale with kind of real world workflows, with kind of some of the constraints operationally you might have, and how do you kind of face to address those? And we couldn't have asked for the better kind of sets of speakers today to discuss this with us, folks from organizations in two of the kind of metro areas in the country, Cleveland and Portland, and kind of organizations that have delivered results at scale and been able to kind of navigate a lot of these challenges. Before we dive into the topics we want to discuss today, I'm going to pass to each of our amazing speakers to give a quick introduction about themselves in the organization they're representing and their role in the organization. And then we're going to kick it off with some discussions here. Feel free to drop any questions you might have in the chat. We're going to try to address as many of them as possible along the process. I'm going to monitor those. And then some of the questions or polls that will come up to you will help us also get insight on who is in the audience and like how you're addressing some of these problems and kind of for you to be a part of the discussion here as well. I want to mention that I forgot to introduce myself. Most of the people in the room might not know me. I'm Nima, Roohi, co-founder and CEO at Blooming, calling from New York City, and we have amazing hosts across the amazing speakers from across the nation and a lot of participants. I was just looking at our kind of registration list. We have folks from tens of states and hundreds of organizations across the nation. So hopefully this will be a fruitful discussion. With that being said, I'm going to kick it off by passing it to Andy. If you don't mind, please introduce yourself. Tell us a little bit more about your organization.
Thanks, Nima, and good morning or good afternoon, everybody. It's an honor to be here. My name is Andy Mendenhall. I am a practicing addiction medicine and family medicine physician. I'm honored to serve as the president and CEO of Central City Concern. We are a 48-year-old community nonprofit organization that started in the housing and affordable housing world and have become, over the last 20, 25 years, a federally qualified health center, healthcare for the homeless designee, serving 12,000 folks annually, with a strong emphasis on substance use disorders and treating folks with severe persistent mental illness experiencing homelessness. Our housing continuum has 2,400 units of owned or operated transitional and permanent housing, and we also provide employment services. This year, we anticipate that we'll be serving close to 18,000 folks within the metropolitan region. And I'm also a population health nerd, so really honored to be here today.
Awesome. Thank you, Andy. Really appreciate you joining us. Looking forward to the discussion. Passing it to Amber from Neighborhood Family Practices, please.
Hi, everyone. Thank you so much for having me. My name is Amber Gravino. I am the Director of Population Health at Neighborhood Family Practice. We're located in Cleveland. We have 6 clinical sites. We're an integrated facility in FQHC. We have multiple services that we offer, mostly primary care. We have behavioral health, midwifery services, dentistry, specialty services. We have community health workers. And then I'll pass it off to Dominic to round it out.
Hello, everyone, and Nima, thank you all for inviting us and putting this together. My name is Domonic Hopson, and I have the pleasure of serving as the Chief Executive Officer here at Neighborhood Family Practice. Our organization is a few years younger than Andy's, at 46 years old, and we've been serving Greater Cleveland for more than 4 decades now with our comprehensive integrated care model, with a heavy focus on the outcomes and the experience of our patients, and we've been heavily invested in our population health work, having Amber lead that work for the last few years. And so looking forward to share what we're doing and how we're doing it, focusing on both our social and our medical complexities of the patients that we're serving. And so let's get things kicked off, Nima.
Awesome. Really appreciate it. Thank you so much again to all of you for taking the time. I want to actually start with a kind of a foundational question. Obviously, for federally qualified health centers, social needs and medical needs are very much kind of directly connected. And I would love to kind of start with kind of understanding for your operations and the patient population you serve, what are some of the key social needs and social risks you spend time on, and then a little bit more context on like why are you trying to solve some of those problems. We're going to get to the how probably a little later in the discussion as well. Starting with you, Andy, please.
Sure thing, Nima. Big picture for us, we identify housing as a primary barrier for many of the folks that we're serving, meaning just getting folks into shelter or into housing. We also struggle in closing the gaps with specialty referral for individuals. And presently, from a social care lens, food insecurity continues to emerge as we evaluate our integrated services and have a large number of folks experiencing food insecurity in our health centers and also in our housing continua. Technology is a primary gap, that meaning this thing that many of us have, most of us likely on this call have, is something that technology gap continues to be an ongoing issue for many of the folks that we serve as well.
Awesome. And Andy, I think you all kind of have a really amazing transition of care model from kind of homelessness and placing people in housing and supporting with them into primary care. Can you give the audience a little bit of a view? How does that kind of integrated model work today in Portland?
Sure thing, Nima. We call it our golden thread, and this this is a continuum of homelessness to medical withdrawal management. We operate a substance use disorder withdrawal management facility serving 3,500 admissions, about 2,800 individuals annually. And then we place folks into transitional recovery housing, provide them access to substance use disorder services level 2 for folks who know what that means, intensive outpatient, primary care services, additional specialty mental health services as needed. And then over a period of, on average, 6 months, folks remain in transitional housing, and then they have the opportunity to get engaged with supportive employment services. And in the face of the fentanyl epidemic and on the West Coast, the P2P methamphetamine epidemic, we're exiting successfully 60 to 65% of our enrollees in that longitudinal care pathway at 6.5 to 7 months with a job and a lease for permanent housing.
Perfect. Amazing. And that kind of gets into the heart of some of the core social problems in Portland, the homelessness problem basically there, and then kind of longitudinally, ultimately kind of addressing healthcare as a part of kind of putting the people back into society and helping them kind of be more integrated economically in their community. Really appreciate all the great work you all doing. Moving to Amber and Dominic, we'd love to see learn from you. What are some of the social needs and gaps you all kind of try to address for the population you're serving in the area, and want to kind of get to understand a little bit the risk profiles you're trying to address, and the care gaps you're trying to address there.
Amber, you get started and I can chime in if necessary, but I doubt I will need to.
Of course, yes. You can always chime in, but I would say like most of the social needs that we're focusing in on is medical referrals. So making sure patients are coming from our facility to another facility for specialty services, cancer screenings, or other ongoing chronic conditions. We see a lot of barriers to care with when it comes to transportation, language. English is not the primary. We're also focused in on maybe the fear of maybe going to some of those cancer screenings. But for the social needs, we focus on food as well. So food, transportation, language barriers. And Dominic, what else do you think would be helpful?
Yeah, you hit it. So we serve over 23,000 patients each year, and around 28% of them prefer to receive their care in a language other than English. So you can imagine that is a significant barrier for the population that we serve. Many of our patients having arrived in Cleveland area as a refugee or asylee. And so not only are they navigating the language barrier, but they're trying to get comfortable in a brand new environment. And so in many ways, we're serving trying to address a broader social need of that patient as they navigate their workplace and their housing. And after they shift off from their resettlement agency, we are that one constant contact that they can reach out to. And so we find ourselves being that go-to, that glue in many ways to help solve a number of those barriers. And some of those are done by Amber and her team and our community health workers. But we also have a refugee support team that is existing there as that primary contact to help people navigate those challenges. And then Amber touched on the food insecurity issue. And we do operate a food is medicine program, helping connect our patients and help solve for that alongside of our local food bank and other partners to help address that barrier. And that is especially one that has become more pronounced as we've seen policy shifts when it comes to eligibility for food support and different programs like that. And so has required us to get more creative around how can we support those individuals that are no longer eligible for our social support systems when it comes to a food access perspective.
For sure. The policy impact is something that we're going to touch a little bit on later in the conversation. One thing I wanted to actually bring to you, Dominic, is we just ran a poll, and around 43% of the people in the audience are saying one of their biggest challenges in kind of aligning healthcare and social care in their practice and their operation is securing sustainable funding for those services. And I was wondering, like, what's an FQHC's like yours incentive to address some of those kind of social needs and risks?
Yeah, that gets to the root of the issue. We hear it from both sides. We hear it from our patients about needing additional support, and we hear it from our clinical providers, both our medical behavioral health, our midwifery team members that say our patients need more help. And in many ways, the services that we're talking about are not directly reimbursed by insurance companies. And so we have a number of ways that we look to fund our model of care. And the first one, honestly, is our investment in value-based care. And so this is something that we've been pouring into our population health and value-based care work for, a number of years now, with though initially not being a real financial return on that investment. But as we've progressed and started to have better outcomes, especially being able to close more care gaps, we've seen the revenue that we are generating from our value-based care arrangements increase. And for us, we are able to almost tie a pretty clear line to that work that our team members are doing to help solve for some of those social challenges that our patients are experiencing. That's one of them. We also participate in a local hub that allows us to get reimbursements from pathways. It's not as much revenue as we would like it to be, but it is some revenue, and it does help offset some of the costs of our investment in this work. but ultimately it really comes down to outcomes for us. And we know that when our patients are healthier, when their outcomes are better, our organization has a lighter lift when it comes to support them. And we know that the country, especially from a policy perspective, will continue to move towards more value-based care enforcement and have more patients and individuals covered through those arrangements. And so we feel like that work, that investment will pay off today, but it will continue to pay off for us in the future. But I would encourage people to start small, identify those individuals, those patients that have the highest burden, the highest social and medical burden, and start to address for those needs. And then once you have a proof of concept, maybe starting with some of your local funders and foundations to see if they can support a small pilot that you then could then go to your payers and other individuals with to have some more sustainable and long-term funding for this work that's critical for the outcomes and for the success of our patients, but also for the health of our communities.
Absolutely. Yeah. I mean, at the heart of it, at the end of the day, there's plenty of research showing that 70, 80% of the healthcare outcomes are a function of the social risks people face. So it's an incentive, like plans are incentivized to do this. I think to be fair to plans, plans also have been somewhat burned out with a lot of different initiatives that promised the outcome, but were not able to deliver the outcome. I think actually FQHCs are uniquely positioned to be very influential in this. And me and you have talked quite a bit about this and like how do you kind of get the coalition of different stakeholders together? Because this is again, there's multiple stakeholders incentives at stake here. Wondering how you've been thinking about this whole process, and I know that social, especially around kind of social needs around housing, is at the heart of your operation, and you guys are kind of following a really strategic braided funding and incentive structure in order to kind of sustain that operation. Wondering like how you think about this and how you try to solve the funding problem for some of the operational kind of issues you're trying to address and then patients' needs.
Sure thing, Nima. First, I would just want to amplify what Domonic said. And I do believe that certainly value-based care is the direction of, and it's grounded in obviously the needs of cost containment and improved outcomes, that interdependency. CCC has actually been kind of early in our journey relative to value-based payment. We're more mature in the space of outcomes related to behavioral health because we've found that we perform very well in that setting, and our patient mix in the primary care setting is actually a lot more challenging for us because of the proportionality of folks that we're serving who are unsheltered homeless or homeless. Or houseless, if you will. To your question, Nima, in a time of scarcity, in a time in our region where clinical acuity continues to increase and many of the care and service models have not kept up with the pacing of a chronic level of service mismatch that exists for many of the folks that we serve, especially those with dual diagnosis. And again, we do this at scale, serving literally thousands of individuals with severe substance use disorder and or severe persistent mental illness. We are in the early stages of expanding FQHC scope, evaluating our covered entity as a whole, and looking at options to bring parts of our historically grant-funded, soft grant-funded supportive housing services staff into, as well as those locations, into scope for our FQHC, recognizing that housing case management and peer-based recovery support services are Medicaid billable. So that's one strategy. And again, we're in the early phase of that implementation. The other thing that we've relied on over the last several years has been Oregon's 1115 waiver program, dedicated on health-related social needs, that's providing both short-term rental support as well as food support for individuals. And we've been central to the workflows being developed and for not only CCC, but for other community benefit organizations and FQs within the region. There has been not as much impact as we would like because that benefit was so diffused across the entire Medicaid adult population predominantly. So Oregon's, I think, results on our waiver are not going to be as robust as they could have been with a more targeted population intervention. Nima, we've got you on mute, just to call it out.
All right, I appreciate it. Thanks, Andy. So I think the 1115 waiver funding and that model have produced some interesting opportunities across different states. Like certain states have been more successful in proving some models that could be sustainable than with health plans. Some states have kind of struggled a little bit further, but overall, I think has been, as you mentioned, kind of a net positive kind of opportunity to showcase some of these whole person health kind of models, the social care models that could address healthcare gaps. I want to turn it back to Amber and kind of talk a little bit more operationally, kind of around social needs, screening, navigation. You talked a little bit about more on a few different kind of areas. You talked about kind of transportation, food insecurity, transportation probably as a part of the clinical care gaps for someone to show up for their appointments and be able to kind of take their screenings, annual checkups, etc. And then you also mentioned some other components like education, like someone that might be scared of doing a screening and needs to be educated how important that screening is to their health. Wondering, like, operationally, you don't need to obviously cover all those kind of elements of needs, but operationally, how do you execute in this? Like, how do you kind of detect some of these needs? How do you try to navigate them for those patients? And then, like, what are the constraints in doing it, basically?
That's a great question. Thank you. I would say, at Neighborhood Family Practice or NFP, we're really good at integrated approach. So we, of course, have screeners for social drivers of health. We use the prepare form within Epic. We're going to be asking patients either on a welcome tablet or my chart if they're experiencing any challenges. But also it comes directly from our providers. If patients are coming in at any point in the care team where they're coming to the front desk, a medical assistant, nursing, any of the care teams and providers mostly, they're going to identify a patient who's having some of those challenges. And our approach is working directly with community health workers. So those providers are either going to have a community health worker on site, which is very exciting for every site, or they're going to submit a referral for community health workers to attempt to reach the patient and help them through some of those barriers, like transportation. They're identifying a need where the patient does not speak English and needs to get to a cardiology appointment, doesn't understand the complex navigating schedule of getting to the main hospital, can't drive either. And then sometimes there's the education piece. Why am I going? I don't, why do I have to go to the specialty appointment? What's the purpose? And the wonderful thing about community health workers is they can establish that trust and relationship with the patient in between those provider visits or specialty appointments. So if there are challenges, we communicate back to the care team pretty effectively and try to close the loop on that as well.
That's amazing. That's great. The kind of follow-up question I wanted to ask, and I'll turn it to Domonic, is neighborhood family practices plays at the intersection of a bunch of different stakeholders, bunch of health systems, health plans, community-based organizations, and we know in this line of business, kind of data interoperability, access to data is like one of the core challenges to address in order to be able to kind of create better integrated care models. I'm wondering how you guys have approached this kind of interoperability problem, how you're solving some of those areas where there is less fragmentation for the patient to navigate and also less fatigue because 5 different stakeholders are asking the same questions from the same patient along the journey.
And this is an interesting point, Nima, where in many ways our healthcare environments locally are dictated by larger systems. That is likely the case in many of the communities that people on the call are serving and supporting patients in. And so sometimes we are at the mercy of our larger partners. They are our referral partners. They are They work alongside of us to provide some specialty services to help solve for some of the social challenges our patients are experiencing. And so for us, historically, one of the easiest ways to reduce some of that friction is now that all of our local hospital systems and our organization are on Epic. And so that allows for us to send referrals back and forth. There is a CERM referral platform that allows us to send electronic referrals and allows us to get updates back whenever that referral changes status. You can imagine in 2026, if we're still sending faxes, which we still have to do at times, but that is not the way that we want to be able to refer and work alongside of our partners. And so whenever you have an opportunity like that, it reduces the administrative lift for both partners, both the provider on the receiving end and us on the sending end. And I would say to go one step further, for us is then now we're working with our social service partners. Historically, healthcare providers have been much more advanced when it comes to our health records than some of our social service partners are. But there are platforms now available that allows our social partners to sign up for and receive referrals and communicate what they're doing and how they're navigating patients. And the other benefit of that is I think, and it's moving to a place where we can see if one of our hospital partners made a referral for a patient that then comes over to us, we shouldn't have to duplicate that referral. We should have the ability to then say, okay, did you go or did you not go? Did you get what you needed from that partner, that provider, or that service organization, which reduces the churn of our patients and allows us to be much more efficient when it comes to supporting them. And then lastly, you touched on the biggest point, Nima, and that interoperability is expensive, right? We know that getting these systems to talk together is very expensive for our organizations. And so having a partner that has done the prep work, they've done all of that analysis to make sure that that system will plug in, which reduces both the time to being able to go live on a project or the ability for us to partner and truly have our systems talk back and forth, makes it much easier for us to make a decision to go with the partner as opposed to one that has our team members having 2 or 3 or 4 screens up at one time within different platforms, because that's still the case, unfortunately, in some areas. But when you ask our team members to do that, they're much more likely not to follow through and support a patient on some of those platforms because it takes them out of their native Epic or health record environment. And so those are some of the ways that we are trying to solve for that, and then continuing to push our partners to come to the table and make it easier for us to partner and to solve for some of that technology or system communication barrier.
Absolutely. Yeah, Dominic, we sometimes kind of half jokingly at Blooming Health say that the future of social care is headless, meaning the staff that are using a tool to navigate social care don't even know that tool exists because it's so much embedded into their kind of day-to-day operating tools. It's kind of a little bit different than the original kind of digital mantras of software as a service organizations where you wanted the staff to be on that software as maximum as possible. Now you want to actually minimize that because first of all, the staff time is so valuable in their kind of one-on-one interaction with the patients and so on and so forth. Plus, technology solutions has just grown out of control. Like we're a technology company. I'm going to actually tell the audience in a second what we do in a few minutes as well. But there's just so many of us, and you don't deserve to kind of navigate all of us. You need to be comfortable. In order for us to help you, you need to be comfortable just using one and be able to kind of have everything kind of embedded into it. With that being said, I'm going to actually go to Andy on this topic. We just ran a poll in the audience here. And by the way, we have around like 160 people on this webinar. So these polls are really statistically representative because we have all segments of the healthcare space. And the question is really kind of what are some of the barriers for you to be able to actually get your social needs into a closed loop stage to be able to address a need. And 39% of people, 40% of people have said lack of real-time data on whether a referred source actually resolved the need. So that those organizations know, do I need to take further actions or not? The second kind of in the order is 30% approximately saying inability to scale personalized follow-ups after the initial identification, because each patient has their own complexities of navigating the care, the documents they need, the household situation they need, et cetera, et cetera. So wondering, Andy, how you guys kind of operationalize some of these social needs, the screening, referrals, and follow-ups in your operation, and how do you kind of overcome some of these challenges?
Thanks, Nima. Those were my top two because I saw the survey, but we weren't allowed to answer. But those were my top two as I look at our challenges here at Central City Concern. We are and have been for the last 3 years using an app-based platform, a text-based platform. And the name of our vendor escapes me. I apologize. I can follow up with that. Where we are doing active solicitation of survey information from a client experience perspective. And we're trying to balance information around how has and is your experience being served by us in different divisions across the organization. And then what are some of your unmet needs? That's how we're aware that more than 50% of the folks that live in our housing are having acute food insecurity, and that number has actually doubled in the last 2 years. So we're at a point right now where we're still using a text-based platform to solicit information. The problem is that data doesn't go anywhere. That data is population wide, and it's in many ways then it's anecdotal. It's not individualized. We don't have a mechanism for getting that information, which is valuable information, into our housing case management software platform, which is Apricot, or into our electronic health record platform, which is the OCHIN iteration of Epic, which we love very much. And quite frankly, at some point, I'd love to see Apricot and Epic, or better yet, see our organization move to an all Epic-based service platform. At the same time, we still need the data acquisition and data entry aspect to move beyond that happening in isolation. I also want to call out that we do have some limitations in terms of many folks are on very limited data plans and or have limited Wi-Fi connectivity. That's actually an area that we're trying to solve within our housing continua and is more complicated than we would like it to be.
Absolutely. Yeah, I mean, these are some of the hardest problems within the population health kind of area to solve. I want to take a minute to tell folks what we do at Blooming. We typically do this at the beginning. I think I'm a little bit of an amateur in hosting a webinar here, so I'm just kind of want to mention what we do at Blooming here and then kind of move on to the rest of the conversation. Basically at Blooming, we have been building technology solutions to address this intersection of social and healthcare, basically addressing social care needs for better clinical outcomes. And we do that through an automated solution that uses a combination of deterministic AI agents that are experts in food insecurity navigation, housing insecurity navigation, transportation, benefit enrollment. And that kind of AI automation layer sits on the top of telecom, could reach people through a text message or a phone call or an email in whatever language the patient might speak, and act as their kind of de facto care navigator along the process. And all of that kind of integrated into a network of community-based organizations like food banks, like housing operations, like social services organizations, and digital platforms like Uber and Lyft Health, DoorDash, et cetera, helping us basically close care gaps from helping a patient that is discharged from hospital to book their primary care appointment, get a transportation right to show up for that appointment, address their food insecurity if they have kind of screened them for food insecurity, get them referral to a food bank, and closing the loop, staying with the member along the process to close the loop. We don't close the loop with paperwork. We actually stay with the member until that need gets addressed. And the member is always a text message or a phone call away, which solves some of the technology barrier problems, that the traditional kind of solutions might face, because we could reach people in rural areas where there's no broadband or even cell phone coverage. There's just a landline. Speak to a person that might be speaking Cantonese, and then be able to basically automate the process of screening and navigation. We serve around 6.5 million to 7 million people across 25 different states. We work with more than 2,500 organizations, from FQHCs to health plans to health systems and community-based organizations. And kind of part of our mission is to address that last mile delivery of social care. And we are very thoughtful about not making it about our platform. Our platform integrates with almost any EMR, any kind of case management solutions, and stays behind the scenes to do the job and feed the information, and which goes back to some of the discussions we have had earlier. With that being said, kind of want to move on to Amber with another question. Amber, one of the things that I think ultimately connects population health challenges and social care challenges to outcomes that payers would care about, as an example, or large systems would care about, is what care gaps are you closing for which segment of population, and what clinical outcome that results in, right? Like example that you mentioned is getting someone to do their screening around cancer screening, because we know that if we could detect that earlier, the cost of caring for that is much, much lower. The dollar cost is lower. The cost on the patient, the hardship they need to go through, is lower as well. So there's clear incentive alignment there to get the patient to kind of get to that appointment and do the screening. I'm wondering if you could give us a little bit of a picture, and this doesn't need to be very comprehensive, but like what other cohorts of populations you guys spend time on, and like what type of gaps you try to fill in for them, which results in certain types of kind of clinical outcomes. And Dominic, you could hop in as needed as well.
Yes, absolutely. And that's a great question. Thank you for asking the question. I would say a lot of our quality metrics revolve around our UDS, so a standard measure of quality, making sure that we're taking care of our entire population at NFP. We also have overlapping goals from value-based care contracts, which are pretty much the same as some of our UDS metrics. So we'll focus on all of our UDS metrics with our providers and our care teams. We go from overarching with tip sheets, just making sure the workflows and the documentation is there on the back end. And then when we look into social drivers of health, that's where we're looking at if we're still missing the mark a little bit, we'll say on mammograms, what can we do to help the patient and meet them where they are? Some of the approaches that we've been able to take with our community health workers is bringing a mammogram van to our clinics to help with access, ease of access. Another example might be a colonoscopy. If we want to get them elsewhere, it's not a mobile unit situation, we can work closely with our community health partners. So developing those strong ties, like Dominic was saying earlier, is crucial. So we can open those pathways for patients, remove some of the barriers that we're seeing with language. Can we communicate more effectively? Can we provide the transportation? Can we offer things like a buddy system? If you have to go for a colonoscopy, that patient can't go alone. What can we do to help support that patient through that process? And education on our end as well. So we really tie that all together, making sure that we're looking at the whole of the UDS metrics, tailoring it to the areas that we need improvement on, and then if we need to, focus in on the social needs as well. You know, what is impacting the patient to get from point A to B, integrating our CHWs for those high-risk patients, and ED follow-up as well, ensuring that we're keeping the patient coming back to primary care so we can prevent a lot of those challenges before they arise over at the emergency room.
Amazing. Yeah, that's super helpful. I don't know if Dominic, you want to add anything, but that was amazing. I appreciate it. Awesome. So I actually want to turn the question a notch harder for our speakers here. I want to understand. I mean, we're talking about some of the hard problems in the population health space. there's many different constraints around it. We talked about some of those and challenges around it. We talked about some of those today. Wondering what is one or two things that you've learned the hard way, like gone through it, done it, and you're like, this needs to be done differently. Went to the kind of beginning and then changed it and did it differently. Something that some of our audience members might want to kind of learn from, especially this kind of intersection of social and healthcare. I know there's a question that might need a little bit thinking, but happy to give it to Domonic or Andy, whichever of you want to start first.
Yeah, I'm happy to start, and I think you have to start by saying change is hard, right? So whatever process that you try to implement, if you have to pivot and do it a different way, it's going to be painful, both for the people that we serve, but also our team members navigating that workflow. But the one that I would say that really jumps out to me is our referral processing. And whenever we're sending our patients out to our partner organizations for medical care in particular. And so we operated a patient advocate type model. And so we had at least one advocate at each site, and they function both supporting addressing social needs, but also processing referrals and sending those out to our partners. And what we found is that we were very inefficient in that model. They did great work, and if there was something that came up on that day, they would solve it because they were on site to do that. And so there was some value in what they were doing. But when we looked at the volume of referrals that we were sending and the success at getting a patient to care, we were not successful in that space. And it wasn't for the hard work of our team members. It was just the workflow, the system matching up the resources with the volume of work. Things weren't aligned there. And it took us almost 2 years, honestly, of tweaking and changing and trying to solve for that until we got to a place where we have transitioned to our community health worker model and have them partnering with referral specialists that are processing those referrals. And now you have a group there that are both processing referrals timely, getting them out, but also a separate team that is supporting our patients who are having difficulty getting over to that care. And so it wasn't a easy journey for us. There were a lot of bumps in the road. I think we started the right way by engaging the people closer to the work and how we changed that process, but it drug out so long and then it got worse before it got better. But I appreciate that our team members, especially our providers and our clinical team members, are willing to work with us. And then for us to say, hey, we have to be more effective when communicating what we're doing, why we're doing it, and then what is the ultimate outcome that we're hoping to experience. And now we've gotten to a place where we've seen a significant reduction in our overall open referrals for our patients and an increased speed around our timeliness of getting patients out, which also allows for us to identify which of our patients need the most support. We know that we can't help schedule an appointment or help provide transportation or coordinate transportation for every one of our patients. But if we can identify the people within our patient base that need the most support and get them connected to a community health worker, or have our referral specialists add a little bit more hands-on connections to get them to where they need, our patients are better off for it. And then our system is more efficient because, as we all know, what happens is you send the patient out, they come back in 6 months for their primary care provider, and they still haven't gone. And then they put in another referral. Now you have multiple referrals in the system for the same thing for that patient, which is only clogging up the system. And so that is one of the things that we've tried to change to help make that system easier for our team members and our patients to navigate. But we did bump our head a few times along the way.
I appreciate it. Thank you so much. And glad that the iteration has resulted in improvements in how you try to navigate this. I think this is one of the problems that there's no real kind of silver bullets around it, and it's gonna need patience to kind of just iterate, and there's going to be areas to improve ultimately to kind of get it to a better ideal place. Andy, moving on to you.
As I think about our health center, the referral issue was the topic I was going to lead with, and very similar pathway and concerns that and journey that we've been on. We've not solve those issues at this point, predominantly due to network capacity to accept referrals within the Medicaid space. But what I will say is that our move, we were a late adopters to the Epic platform, having gone live in January of 2024, prior to that being on Athena's Centricity system long enough for it to be operationally sundown. And so the cup is half full version as we moved from spreadsheets to automatic reporting with the Ocean Epic iteration, which was a game changer for us. And acknowledging that we still have that last mile challenge with many of our unsheltered or unhoused or unstably housed folks. And that continues to be a challenge for us, both in terms of connection and continuity. I think what's of equal interest to us is the gap that we've been working to close between our housing continuum and our healthcare continuum as a whole, and creating better situational awareness between those two divisions. Where we've been innovating is we have some members of our housing staff now able to, based on the treatment of our covered entity and signed releases and training, have seats within the Epic platform. So we do have folks supporting some of our regulated permanent supportive housing, able to document in both places. I do think my long-term vision for Central City Concern is certainly about creating true integration, which for us and for me looks like documentation in one record with the modules appropriate to help folks navigate the healthcare system and navigate the housing system, which in our region continues to be its own silo with its own set of compliance and regulatory elements. And unfortunately, variance in the prioritization of who gets what access to different resources, resulting in continuum disruption, especially for folks that suffer from different conditions or different disease states that truly require a longitudinal continuum operating at scale. Trying to make that cup half full.
Yeah, yeah, absolutely.
We know we're aimed in the right direction.
Absolutely. Yeah, I think some of these kind of in-between stakeholder organization problems are some of the hardest problems to solve within this space. We talked about the interoperability, but it's not the only kind of piece that needs to be solved. Even when you have interoperability, you still need navigation. The patient that gets handed over to another organization needs to navigate a new process, basically. And depending on the need, depending on the reason, depending on their life situation, as an example, if they're a caregiver and they don't have any accommodations to take the actions on that follow-up, a lot of things could kind of break the system in that process. And it's a tough puzzle to pull together in different pieces. I want to talk a little bit about the policy impact and some of the work you all are doing. Could start with you, Dominic, on this one. Obviously, there is a lot of kind of federal level impact on Medicaid and some of the elements that impact Medicaid population. You talked about like food insecurity, specifically around kind of access to food stamps and other types of kind of supports and services. I'm wondering, like, first of all, what are your general kind of thoughts on how to navigate some of these policies? What risks it might create for you, and then if there's any kind of silver linings, opportunities, et cetera, that it might create along the process to better address the population's needs. I'm wondering, like, how are you thinking about navigating it?
The first thing for us is being informed, right? Things are changing so fast. We're, a few weeks in some cases away from some of these policies starting to go into effect, and some rules are still rolling out. And so just being informed as you can be on what policy changes are coming and how they impact both the organization and the patients that you serve. And of course, that also comes with some advocacy that we all lean into. And for us, it's trying to do our best to make sure that our legislators, our policymakers have a face to the policy that they're making. They have a clear understanding that this decision here will impact this group of people in the local community that you are representing. Is always a key priority for us. But once you move on from that and once it goes into effect, trying to be as proactive as possible. And so we talked about what happened with eligibility around food support. And so I think that was an opportunity for us to learn as a community how to navigate that, what it looks like to support people who no longer have a benefit that they have been dependent on and still need for a long time. And we're trying to use those lessons to implement that as we prepare for some of these Medicaid changes. And so for us, there's two key things that we're doing. One is a collaboration, a partnership with our local healthcare partners to say, how are you going to address this? What is going to be your approach? Because we share patients across our system. And so for us, trying to find a way to align where appropriate with our partners so that our patients aren't so confused whenever they're having to get care in different spaces. The second one is to identify who's the right partner that could have the most significant impact on our community when it comes to helping solve for or educate them on this process. For that, for us, it is our county job and family services department who are the ones who are screening and processing applications for Medicaid or managing some of the redetermination work. And so we were able to work with a local funder, a local foundation to apply for a grant that resulted in funding that gave us the support to hire an additional financial counselor ourselves that helps people apply for Medicaid, but it also allowed us to pay our county to have a dedicated analyst that reviews and processes those applications. And so that person will be housed within our organization, sitting right beside our financial counselors. And so when we are submitting those applications, we can then work with that person to understand how is that going? Is there something different that we need to do or that patient needs from you? Those have been some of the strategies that we've been implementing. And I would say ultimately, Nima, is to try to be as proactive as possible. I shared earlier that we do have a significant portion of our population that are former refugees or asylees. And so we know that on 10/1, they're going to lose their Medicaid coverage. We have not waited around to October 1st. We have been working, planning, putting processes in place, and then reaching out to our patients to say, hey, you could be at risk for this. Make sure you look out for communications from these providers. Let's go ahead and get you signed up for our sliding fee scale right now, today, and then communicating to our patients that we are still here for you, regardless of how your health insurance changes. Because if you wait until they get that letter and they withdraw from that system because of confusion or because of their concern about the cost, it's so much harder to get them back connected to the system. And so those are some of the strategies that we have put into place. Of course, only time will tell how successful we are with, again, having about 6 weeks before we start to see the refugee impact. And then, as we all know, on January 1, we'll start to see a broader impact across our Medicaid, especially our expansion population patients for those who are operating in the expansion states.
Absolutely. Appreciate it, Dom. One thing I wanted to mention is that Blooming, we're spending quite a bit of time on Medicaid recertification and SNAP recertification, Medicaid enrollment and SNAP enrollment. You could think of our platform as a solution that would be able to help educate people, first of all, what is coming up, then help them pull together the documents they need, then help them fill out the forms needed, prepare the packages for submittal. Obviously, there's always complex cases, which is what Dominic kind of referred to, where you need to actually a financial counselor to help the person navigate some of the challenges they might face in order to figure out their eligibility. But we package the paperwork, we fill out the form. We try to do this at scale. In fact, we're rolling out in Cleveland with some of the partners in Ohio. We already have done in New Jersey and New York. We're right now, as I speak, we're doing it in California, helping basically supporting patients to stay covered. This starts early, as Dominic mentioned. Education is first piece. Like most people don't even know this is happening. And because of the job requirements, employment requirements, the problems need to be surfaced and addressed more in advance. You're not going to be able to help someone get volunteer work or part-time work 2 weeks before they lose their coverage. This needs to happen a little bit in advance in order to address some of those foundational gaps. We would be happy to talk a little bit more about this with some of the folks in the audience that might be interested to see how we are helping this. I want to pass it to Andy to see basically what are some of your thoughts about the policy impacts before we wrap up here.
Oh, sure thing, Nima. I just stole your thunder. I put a couple thoughts in the chat. I just wanted to say, I know I'm gonna project and assume that everybody on the call is as concerned about disruption and continuity of service access for the folks that we are serving as anyone else in the FQ space. We are advocating actively for technology solutions to augment any additional human beings to do the work. And so that is a platform, and I think a value proposition that is worthwhile for any FQ, any accountable care organization, because in Oregon everything has to be different and labeled differently. In Oregon, they're called coordinated care organizations. The opportunity I think exists to say, how do you take your existing workforce, augment their ability to maintain and manage individualized relationships and prioritize their time and efforts for maximum benefit. And I see the logic and the outputs from leveraging technology during this time, not only in response to these issues and challenges, which I certainly hope are seasonal related to Medicaid, but to the broader benefit of what is engagement of vulnerable populations look like and need to be moving forward, regardless of the demographic being served.
Awesome. Really appreciate it. And last but not least, I want to give Amber a minute because I know, Amber, you work on the front lines of this and probably navigating a lot of anxious patients and some of the help they might need. Any thoughts you have about what you're seeing on the front lines and how you all are planning to address some of those?
That's a great question. Thank you. I would say, to Dominic's point, we are trying to be as proactive as possible, working within our own departments, to make sure that that relationship of the patients who have been coming in, reaching out to them in advance education, making sure that we're communicating in the same language too, so they understand what's happening, and ensuring that the follow-up still coming back to neighborhood family practice, because we can still take care of patients with our sliding scale fee. And there's also programs available for some of the screenings. We have a breast cancer or cervical cancer project that helps with PAPs and mammos free of charge for patients. So looking for opportunities to make sure that patients are not only on our sliding scale fee, but also on those programs that will take care of some of those open care gaps as well.
Appreciate it. Thank you so much. I want to appreciate Andy, Dominic, and Amber, your time today, sharing your experience, the amazing work you all are doing in the communities you're serving. We think very, very highly of you and the amazing work you're doing. We really love federally qualified health centers because they're one of the most trusted healthcare providers in this country. So appreciate all the amazing work you're doing. I hope this was productive for the audience members here as well. If you want to reach out to Andy, Dominic, Amber, you could basically use their email addresses to reach out to them. If you want to continue the conversation, we're happy to kind of discuss anything we could support you with. We appreciate you taking the time today. Thank you so much and have a great rest of the day.